Good afternoon and welcome to Dementia Australia's webinar, Understanding MND and Dementia. My name's Gary O'Toole and I'll be your host for today. Apologies for being a couple of minutes late. We're just sorting out a couple of technical difficulties in the background, but we shall get started nonetheless. So to begin with, I'd just like to acknowledge the traditional owners of the lands on which we meet today. I'd like to pay my respects to elders past and present and to our shared futures together. Just a couple of quick housekeeping points. Just a reminder that your cameras and your microphones have been turned off for the duration of the webinar. If you've got any comments or any questions, and we love to hear your questions, if you could just type those into the chat box, and Taylor will be having a look at the questions, and I'll get to stop a couple of times throughout the webinar just to ask for questions for the panel. If you particularly like a question that somebody else has asked, if you could like that, and it'll bump it up the list and make it easier for us to identify it. So I'd like to probably first off introduce our panelists. Some of them are still getting into the system, but if I could introduce Sally Connell. Sally is an allied health educator at Illawarra Shoalhaven, local health district, apologies, Sally, and we really welcome her and her expertise. As well, we have Julie Labra, who is with the Motor Neuron Disease Australia. Welcome, Julie. So while we're just waiting for the others to join us, I might throw to Sally. Sally, I wonder if you could describe a little bit about, for our audience, a little bit about motor neuron disease and some of the cognitive issues and I suppose the dementia that's associated with motor neuron disease. I think for a lot of our audience, we won't be all that familiar with motor neuron disease, and particularly that cognitive aspect.
Thanks so much, Gary, and please feel free to jump in, Julie. I know this is also your area of expertise. So motor neuron disease is a progressive neurological condition. And you're right, Gary, in that a lot of people don't really associate it with the cognitive side and the cognitive deficits. A lot of people think of the functional and muscle deficits in that condition. But research has found that, over 50% of people with motor neuron disease can experience changes in their thinking and their behaviour. So most people will experience a relatively mild change, but predominantly most of the people we're seeing with motor neuron disease will have some level of deficit. However, up to about 15% of people living with motor neuron disease can show signs of frontotemporal dementia. And that's dementia of the frontal lobe here, which really manages a lot of our executive functions, our problem solving, and about our inhibitions and behaviours. So some of those people may receive that diagnosis of frontotemporal dementia, and some of the changes that we can see is that they have more difficulty processing information, and they can't really think as quickly or as on their feet as someone without that diagnosis would. They might have difficulty focusing or concentrating, so some of those big conversations and complex conversations that we have may be missed for them. They'll have difficulty planning or organising tasks and planning ahead. Decision making can also become quite challenging because that's part of problem solving and that executive function that we see with the frontal lobe. Learning new things as well can be difficult. And there's some links to some changes in their memory and recalling information. I think in terms of behaviour, what we often see is they can become a bit withdrawn or have a bit of apathy. So they're feeling less motivated and losing interest in some activities that they once liked. and also being quite rigid in their thinking as well. So some new things or changes can be really quite challenging to accept or move forward with. And I think, when you think about MND as a whole, that makes it very difficult because our body is changing every day, every week, every month. A person can also become quite impulsive. They may say or do things that is without thinking about the outcome of it. So things like falls could be a bit more of an increased risk. They also can have some disinhibition because of that frontal lobe involvement, where we might have some behaviours there. They say or do things that are not really appropriate in that context or in that social situation. We may also see them being quite emotionally labile, so they might have often rapid or exaggerated changes in their mood. They could go from uncontrollably laughing to crying, and that may not be an appropriate emotion in the context of what's happening.
Thanks for that, Sally. It sounds quite a different presentation of the cognitive changes that I suppose, again, many of our audience would be more familiar with, some of the disease like Alzheimer's disease or even vascular dementia.
Yes, I would agree with that as well. And I think that it can make that, again, more challenging because, in a way, dementia and some of those common dementias are talked about and known quite well. We do kind of know what an Alzheimer's dementia can look like, and this frontotemporal dementia can be very different, in particular about those emotions, those behaviours, those risk-taking kind of scenarios as well.
Excellent. Thanks, Sally. Now, I think we may have Dr. Marie-Claire Davis has joined us. Are you there, Dr. Davis? Possibly not. Okay. Jane, are you there?
Hello, can you hear me?
I can hear you very well. Thank you very much. On my screen, it just says meeting guest. I wasn't quite sure who it was. Thank you for coming along, Jane. And I do apologise if we had a couple of technical difficulties getting you online. We really welcome you. I'll just introduce you to our audience. Jane is the chair of the Lived Experience Research Advisory Panel with MND. She hosts a regular podcast called Let's Talk MND, and she has herself quite lived experience with motor neuron disease, having supported her husband who was diagnosed with the disease a number of years ago. Jane, I wonder if you could give us a little bit of your personal experience, your journey with MND, just to, I suppose, set the scene for our audience. Jane, we might have lost. Yes, Jane.
This is Marie-Claire Davis.
Oh, sorry. We're having a few challenges this afternoon. Dr. Davis, I wonder if you can explain for our audience then a little bit about the causes and the pathology, I suppose, of motor neuron disease. What people are when they're normally diagnosed, what's happening to their neurological system as a result of this disease process.
Certainly. So damage to the frontal and temporal lobes of the brain cause the motor and cognitive symptoms in MND-FTD, which is where we get the term frontotemporal dementia. And the damage to brain cells is caused by dysfunction in how the person's brain cells regulate the production and use of certain proteins. So these proteins start accumulating and interfering with brain cell function, and eventually the brain cells start dying. So it's the same pathology as the more prevalent frontotemporal lobar degeneration or PIX disease that causes the different FTD syndromes and primary progressive aphasias.
How common is motor neuron disease in the community?
Motor neuron disease?
Yeah.
That's a good question. The prevalence seems to be increasing.
I can tell you the number, Gary, that the number of
thanks,
people
Julie.
living with MND in Australia at the moment is about 2,200 people around the country, but not all of those will have this FTD type of MND.
Yep.
Thanks, Marie-Claire.
Back to you, Marie-Claire. What sort of age do people normally start showing some of those neurodegenerative signs, and how easy is diagnosis?
So, as a neuropsychologist, the patient group I see are really those affected with MND FTD rather than MND more broadly. So I think, as Sally mentioned, about 50% of people with MND, particularly those with the most common form of motor neuron disease, which is amyotrophic lateral sclerosis, they will experience some form of decline in their cognition. And then within that, a subset of 5 to 15% will have impairment so severe that they get a diagnosis of MND FTD. So back to your question about diagnosis, and I guess the way we think about it is MND on one end of a spectrum and FTD on the other end of the spectrum. And often people will first develop FTD symptoms, so those very early cognitive and emotional and behavioural changes, and progress. As they progress, their FTD becomes more overt, and then they may go on to develop some symptoms of MND. Other people, however, tend to begin by manifesting amyotrophic lateral sclerosis or another MND syndrome, and then go on to develop the cognitive and behavioural impairment. But the thought is that it's the same pathology, just beginning in different parts of the brain and then spreading. So for those with MND, it begins in the motor cortex, the primary motor cortex, and spreads from there. And the other way around for those who start with an FTD presentation.
It sounds a little bit to me, a little bit similar to Lewy body disease and Lewy body dementia, with Parkinson's at one end of the spectrum and Lewy body dementia at the other end of the spectrum.
Yes, yeah, that's a good analogy. Yeah, so the same alpha-synucleinopathies, I think I pronounced it
very good.
as the underlying pathology, but beginning with different presentations.
Excellent, thank you. I might throw to Julie Labra, if I could. Julie is the project manager at the National MND Lived Experience Network. Julie, I thought before we talk a little bit about MND, if you could talk about your role at MND Australia and the Lived Experience Network.
Sure. Yeah. Hello, everyone. Good afternoon. My name is Julie and I work for MND Australia, but very much from a health background. So I worked in a clinic, a specialist MND clinic for many, many years, but now working at MND Australia in a project manager role to deliver our national MND Lived Experience Network. And actually, I worked a lot with Dementia Australia, with some of your lovely team members on helping us to design our model based on the model that you guys have with your Consumer Advocates program, which runs so beautifully, I believe. So at MND Australia, we have in June launched our Lived Experience Network, and we now have about 130 people with lived experience from the community all around Australia who've signed up to be part of this initiative. And the goal of it really is to connect those people with lived experience with professional organisations, whether that be healthcare professionals or researchers or NGOs, with those organisations who are looking to connect with people with lived experience, so that we can all be working together more and collaborating more on different projects and initiatives. Yeah.
Excellent. Thank you for that description of your role. It's such an important part of the work you do at MND and we at Dementia Australia in amplifying the voice of people who are affected by these conditions, I suppose.
Yes.
Julie, I wonder if you could also just talk a little bit about some of the I suppose the significant challenges in meeting activities of daily living and socializing and staying connected to family that people with a diagnosis of MND, in particular with MND and FTD and frontotemporal lobe dementia, experience.
Yeah, that's a huge issue, and when people are first diagnosed, they're already starting to present with cognitive deterioration when they have this type of MND, this MND with frontotemporal dementia. When they first come in and see the doctors, the families will be quite frustrated, and not sure what to do or how to cope with these behaviours or the changes in the thinking. And they don't know what's causing it. Certainly people become much more withdrawn, and they don't like to go out anymore, and they don't like to interact with family. And so it has a huge ripple effect on the entire social network that person has. But on top of that, yes, there's the cognitive problems, but there's all the other problems that can also come along with motor neuron disease. So yes, there's cognitive changes, but they might also have problems with their speech or their communication. So, you know, what they're saying to you might not make any sense because their articulation is so poor. And so there's that added layer of frustration that they are dementing and their behaviours are changing, but you also can't understand their speech. So it's super hard for all involved. And on top of that, they might also have lots of drooling or problems with their saliva, which they're incredibly embarrassed about, and they don't want to be near people because they might be drooling all over the place as well. So there's all these multifaceted issues that come along with the disease that impact on the social connections.
Excellent. Thanks for that, Julie. And Sally, I'll throw just to you, based on what Julie's explained to us. I suppose it's the role of care workers, personal care workers, allied health, nursing staff, how they work together to provide this very multifaceted, holistic care that people with a diagnosis of MND do require. Just wondering if you could make a couple of comments about that.
Yeah, I couldn't support that more. I think with this kind of disease, motor neuron disease, it's so important that we have a whole team of people involved with the care every day, every week, every month throughout their journey. It's such a complex and a progressive kind of disease. So it is really hard to get on top of for families, for the person themselves. You know, you think, okay, I know what my body's doing now, and then the next week something else has changed and we're back at square one trying to figure things out again. So I think by having a multidisciplinary team, what that means is you have your specialist doctors, your neurologists, you have your carers, your family, you have allied health, which can be physiotherapy, occupational therapy, speech pathology, a dietitian, social workers, as well as psychology as well. Like, it's quite a big team, but by having lots of those people involved, we all have our specialties kind of in each of those body systems. So we can have that multidisciplinary approach and look at each of those symptoms and each of those changes from our different perspectives. And all together, that means that we can hopefully manage what's happening for someone as best we can. And I think, as you mentioned before, the carers, whether they're informal or professional carers, are really crucial in that. They're the people that kind of bridge bridge between home life and medical life. You know, they're the people that are seeing them every day. They'll notice these changes as they're happening, and they'll be able to sort of see those small changes and relay that information and, you know, advise family, oh, I think we need to get the speech pathologist back out here because they are drooling a little bit more or their speech is a little bit different. So I think it's really key that we do have a lot of people involved to manage all of the symptoms that come along with motor neuron disease, and to just make sure we have a really true coordinated approach across medical, family, carers, everyone that's involved.
Thanks, Sally. I know this is sort of a question both for Julie and Sally, and perhaps Marie-Claire. I'm wondering how many people with a diagnosis, particularly later on in the disease progression, require nursing home or aged care facility support. Do we have, how many people actually will spend the last part of their life in the aged care facility? Julie?
Gary, we don't have, I can't tell you the exact number on that, but I can tell you that from our experience in the clinic I was working in, but also we did a survey of people living all across New South Wales with MND, and we think the figure is around about between 5 and 10% of people with MND in a nursing home. So it's probably lower than what you would expect, given the high levels of disability that come along with this disease. But I can tell you that the people that do end up in aged care facilities, that it's often a tremendously difficult time for the person and the family, because unfortunately the nursing homes really just aren't designed to cater for people with such high levels of disability and cognitive decline on top of that. Yeah, it's a real challenge.
I can only imagine. Sally, have you got any pointers that perhaps that you would provide for our audience today if they are working in residential aged care facilities, perhaps working in community care, perhaps without the backup of that big allied health team and expertise within the MND area? What are some of your tips for success?
Well, Gary, that's a big question.
I like big questions.
I do think firstly, like tips is MND New South Wales and MND Australia websites really are great. They have wonderful fact sheets, really relevant information there. I would have to say, though, biggest tip is you need to find your people, you need to find your team. You know, you cannot manage this disease for the whole, you know, journey of it as one or two people. You really do need to link in with a good specialist and try to find an allied health team. I just think it's so important that you have speech pathology involved to help manage some of those communication difficulties. A speech pathologist will find personalised strategies for that person and for that carer to try to manage the changes physically with their speech, their saliva, as well as those changes with the dementia side of things too. You know, physiotherapy is really, really required when we have breathing and respiratory changes as well. So I think some of the top tips, try to find your people, try to find your team. There's usually MND clinics in each kind of LHD, and, you know, us in Illawarra here have an MND clinic, and anyone with that diagnosis can be referred, and that's a free service. So there are clinics around that are available to people to get that specialist advice and input ongoing. And I think having good communication between all those services, between specialists, your GPs, your paid carers, your NDIS coordinators, is really key as well. Yes, Julie, you probably have something to add.
No, that's super, Sally, super good. I was just going to add one thing, a really important tip for this type of motor neuron disease when there's frontotemporal dementia associated with it. I cannot stress how important it is to look after the carers, the loved ones, the family. So because they really struggle and are battling out there, particularly if the person is living in the community at home. The families are often beside themselves with stress, fatigue, exhaustion. They don't know how to manage their behaviours, and it can become incredibly overwhelming. So it's really important for any carers in the home or healthcare professionals to be regularly checking in with the family, with the loved ones, see how they're doing, asking what they need and what support can you give to those family members to just keep them going for as long as they can. If you can find a place for respite admissions, that's can be incredibly helpful to give people a break. If not an admission, then certainly respite in the home is crucial to be backing up those family carers.
I think that's such an important point, Julie. I think, and it's certainly experience in dementia generally, and probably in healthcare generally, is that sometimes in the rush to focus on the needs of the person with the diagnosis, carers can get a little bit sort of lost and sidelined, and we see, I spend a lot of time in residential aged care and talking to family carers, and it can be so difficult to find the supports that they need to be able to manage and to manage well.
Absolutely. That might be a good segue to Jane. Are you on there, Jane, our carer, lovely carer, Jane?
She is indeed, and thanks, Julia. That's exactly what was going on in my mind. So I would like to welcome Jane Simpson. Jane has been a carer of somebody with motor neuron disease. As I said before, she's also the chair of the Lived Experience Research. I don't know why I'm having so much trouble with that word. Research Advisory Panel, and Jane very, very kindly is joining us on the phone. Jane, I wonder if you could tell us a little bit about your journey, some of the, I don't know, some of the challenges, but also some of the rewards. It might be a strange word to use, but a little bit about your experience supporting somebody with motor neuron disease. Jane.
Can you unmute her?
Doesn't.
Jane, could you unmute yourself, please?
Not looking like she can. Okay, I might come back to Jane a little bit later. We can work out why she's being muted. Marie Claire, I'm just wondering if you could tell us a little bit about where we are in terms of treatment of motor neuron disease, what's happening in the research area. I know a lot of attention in the public sphere is being placed on raising funds to support research into treatments. Could you tell us a little bit about where we are at the moment?
I'm afraid that wasn't one of the questions I was.
Sorry, I threw it in at the last minute.
Yeah. So I haven't had a look at the more recent research. We do a lot of research here at Calvary Bethlehem on primary pathological treatments. As far as managing the frontotemporal dementia aspect of it, unfortunately, it is still around positive behaviour support management and pharmacological management, really, of behaviours of concern.
Thanks for that. Yes, Julie.
I can add a little bit to that, Gary, if you like, in terms of available kind of treatments and interventions. Look, with the disease, with motor neuron disease generally, we're very limited in what we have available for treatment as such. I mean, there is a medication called riluzole that people can take that will try and slow down the progression of disease, and it can prolong survival by between 6 to 19 months. So we know that's a tablet, a medication people can take. There is a new drug called tofersen that has come out for people who have a SOD1 genetic mutation, which is only a very small number of people, and that drug can also help to be slowing down the disease. There aren't a lot of other treatments available. We are quite limited. There is heaps of research happening. But there are other interventions that can help to improve the quality of life for people, or in many cases prolong survival. The main interventions in motor neuron disease are linking with a motor neuron disease clinic. We know that can prolong survival and quality of life is improved. Linking with palliative care, that is considered an intervention and is critically important for people with this type of frontotemporal dementia, the MND, FTD, that type. It's so important to get palliative care involved, because often with this type of motor neuron disease, they can't have the other standard interventions that other people with motor neuron disease might use. And by that, I'm talking about a PEG tube or a gastrostomy tube for feeding, and also a BiPAP machine, or what you call non-invasive ventilation, which is for breathing, a mask that people use for breathing at night while they're sleeping. So the PEG and the BiPAP can help to be minimising weight loss and providing a port for people to get calories and nutrition through. And the BiPAP can help with symptoms of breathlessness and a better sleep quality. The problem when you have this type of MND with FTD is that often they're the cohort of people that it's not suitable to be giving them a PEG or a BiPAP, because they simply can't tolerate the procedure. You know, having to go into hospital for a surgery is too much for someone with frontotemporal dementia to have the PEG put in. Or, you know, I've had people where that's been done before and they've simply just pulled it out after the surgery. And the same with the BiPAP. They can't tolerate that mask over their face while they're sleeping at night. It's just too much for them. Whereas when somebody doesn't have a dementia on top of their MND, they can often tolerate those types of interventions. So, you know, that's why it's so important to get palliative care involved with this frontotemporal dementia, because they're likely to progress a lot quicker than other types of motor neuron disease. Their nutrition will usually deteriorate very quickly with their swallowing, and their breathing can also deteriorate at the same time. So if you've got the cognition, the breathing, the swallowing, the weight loss, all combining and deteriorating sometimes on a monthly basis, someone can really go down very quickly. So that's where palliative care support is crucial.
It sounds really critical, and we might talk a little bit later about the whole concept of advanced care planning and how that fits in with palliative care. But I'll throw now to Jane Simpson. Jane,
I'm here.
Oh, we're so pleased to hear you, Jane. That's
Yippee!
lovely. Look, sometimes the technology gets the better of us, but thank you for your patience.
It's a pleasure, Gary.
I wonder if you could just tell us a little bit about your experience, your journey with motor neuron disease, and the support that you provided for your husband, and a little bit about your current role at motor neuron disease as well.
that hard word research. Yeah. Okay, so hi everybody, and I'm sorry for the technical delays. I'm Jane. My husband Robert was diagnosed in 2021 with motor neuron disease in the February, and just as Julie was saying a minute ago, he went pretty quickly. He died in December of 2021. You might notice the date there is around COVID. So two things. Although I don't look it, I married an older man. He was over 65. So we were not eligible for NDIS. It was COVID. The health systems were in absolute chaos. So it was me and he. I cared for Robert 24/7. I did, as Julie just mentioned before, because sadly for us, our son had died about 10 years earlier. So I understood the worth of palliative care. So I called PALCare in very, very early with us, like the first week. We were able to get 4 hours a week of aged care help. They came in to help me shower him, but basically that was all that we could have. How did this affect our daily life? Well, there was nothing except for the care of my husband. He deteriorated very quickly, and I think he also had some frontal lobe dementia, but because it was COVID, because he went so quickly, it just wasn't easy to have that diagnosed. But he had changes that I, being just a normal Jane Blow citizen, think it was. My entire life, for 24 hours a day, 7 days a week, was caring for him. Yeah, and what I do now is I am heavily involved with MND Australia, MND Vic, Fight MND, and as Gary mentioned before, I'm the chair of the Lived Experience Research Advisory Panel. And that's a group of about 100 people with lived experience in MND. And we are directing the way that research should be going, not necessarily where research was going. So what's important to us?
It's such an important role to have the people with the lived experience actually having a voice, particularly in terms, I think, of research priorities.
Correct.
And it's something we're I don't know, I've been around the healthcare area for a long time. I think we saw a change with HIV where people who were diagnosed started speaking up and yeah, challenging, I think, some of the ways health professionals thought. So thank you so much, Jane, for what you have done and what you do. Jane, I might just ask, no, I might ask that a little bit later. I'm interested in what your advice for healthcare workers, particularly within the residential aged care sector or the community sector, a lot of our audience are, what are important messages that they need to consider, but I'm going to ask that a little bit later. And I might turn to Taylor Fleming now. Taylor has been monitoring the chat. Taylor, have there been any questions?
There's been a lot of questions, Gary. It's a very busy which is very exciting. So the most liked question is actually 3 questions in one, and those are: is MND hereditary? Is there a genetic predisposition to developing MND? And are there any known risk factors for developing MND?
Can I jump in there? Jane
yes,
speaking.
please. Yep,
So,
please do.
About 5 to 10% of MND is familial. 90% obviously is sporadic. There are known genetics within familial, and we don't know what triggers it. So in one family, you may have people with the SOD1 or SOD3 gene. Some people may get it. Some people in that family may not get it. Then again, sometimes entire families do get it. But with the 90%, my husband was sporadic. We don't know where it comes from. We don't know why he got it. Absolutely no idea.
Marie-Claire, did you have anything that you wanted to add to that question?
Certainly. So there's another common genetic mutation called the C9orf72 gene, and that is quite heavily associated with FTD in MND. And again, it's part of that 5% of people with a clear genetic mutation and familial history. As far as environmental risk factors go, there's ongoing research about exposure to different environmental pollutants and all sorts of other things that are continuing, but nothing definitive at this point.
Okay, thank you. Taylor, any other questions?
Yes, just trying to pick which one would be the best. So there's a few along the same lines, which are basically saying or asking whether all people living with MND will eventually get dementia at some point.
No,
Julie.
they don't.
I'm sorry, that was Jane?
Yeah, but Julie and I talk together, so she can finish.
Excellent. Julie, did you want to make any comments?
Yeah, James, yeah, the answer is no. Not everybody who is diagnosed with MND goes on to develop dementia. Probably 50% of people with MND will develop some kind of cognitive problem, but only about 5-ish% will actually develop MND with frontotemporal dementia. So the end of that spectrum with very severe cognitive and behavioural impairments.
Excellent, thank you. I might just as an aside mention that MND Australia and Alzheimer's Australia, gosh, I'm living in the past, and Dementia Australia have collaborated in putting together a module, an education module in our free app, which is Ask Annie, and we'll just pop into chat, and also hopefully we'll be able to share a screen with a QR code. If people wanted to, there it goes. If people wanted to access the app, it's free and has a wide range of modules available, both on all forms of dementia, including this new module on MND. We're very proud and very pleased to have been able to work with Motor Neuron Disease Australia in putting that module together. So really encourage people to have a look. Okay. So I want to turn back to Julie just for a moment. We mentioned you mentioned the importance of palliative care, and one aspect of palliative care, obviously, is the crucial aspect of advanced care planning or advanced care plans. Julie, I wonder if you could talk a little bit about the importance of advanced care plans.
Yes, I think, look, for anyone with any kind of neurodegenerative condition, advanced care planning is really important, but it's particularly important for someone with motor neuron disease, and even more so if they have this MND with frontotemporal dementia. And the reason it's so important is, as we've previously mentioned, is just how rapidly people can change. So it's not like a normal dementia where people can live for many years, many years in the community with dementia. If you have MND with frontotemporal dementia, we could be talking less than 12 months that somebody might survive from the time that they're diagnosed, and that's getting worse week to week, month to month, right? Mm-hmm. So having those conversations with the person, if they're capable of participating in those discussions, is really important. If the person no longer has the capacity to be participating in those complex discussions about advanced care planning, then it's really working with the family and talking through the care planning with the family, because often the family, one of the most stressful things for them is looking ahead and thinking, I don't know what's going to happen. What's how is my loved one going to deteriorate? How are they going to present? And who do I call when that happens? Or what should I do? Where should I take them? You know, how am I going to care for them? So all of these questions are running around in people's heads, particularly the family. So they need those discussions to happen as early as possible. Having said that, there are many families who simply cannot go there. When you try and bring up advanced care planning and say, look, you know, it's a good idea we start talking about these things, they will shut you down and they won't want to go there. So you really have to not back away, but you have to stay involved and maintain a rapport, build trust with people, and gradually you might get there. They'll allow you to have those discussions. Other families want to know about it straight away, and they're like, yes, we want a care plan, and so you get in there and you get it done. But the beauty of an advanced care plan, you know, it's the discussion that's the most important part. Yes, you might end up with a piece of paper or a letter or some kind of document you might use, which is great, but it's the discussion and the talking with the family that's the most important part of it. That is what provides reassurance for people in their mind. It's really important that there's an understanding of, well, who is responsible? Who's the person responsible for this person living with MND? If they can't communicate their wishes, who are we talking to? Who should the doctors be talking to? You know, do they have a preferred person that they want the teams to be talking to? That is the most crucial part. You know, is it the husband? Is it the what? Is it the son or the daughter? Do they have an enduring power of attorney in place? So talking about who is the person responsible is crucial. Having some understanding of the person's values and beliefs it is really important. And having discussions about what is that person's preference for medical interventions. You know, if they land in a hospital and they're very unwell, are we thinking we might put a peg tube in this person? Or are we thinking we might try a BiPAP? Or are we not going down that path? We're not aiming for inserting a peg or trialing a BiPAP. We're really just aiming for palliative care, keeping someone comfortable with symptom management from the palliative care team or the nurses. So it's really important to know and document which interventions this person might be going for or not. So that if they land in an acute hospital, then and you have a care plan documented, the emergency team can straight away say, oh, okay, we've got a care plan. We know that they don't want this, they do want that, and this is how we're going to plan the care. So it can save a hell of a lot of time and really tense discussions in a very acute situation, which you don't want to be having those discussions in an acute environment. It's too stressful for everybody. The other really important aspect of advanced care planning is knowing where the person would like to be cared for at the end of their life. You know, do they want to remain at home? Or no, they don't want to be at home. They'd prefer to die in a hospital or in a palliative care unit. So if somebody has very, very strong preferences for one or the other, then the community teams involved can try and then help to achieve that goal for that person. So all of these kind of very complex discussions are really important, and some people you'll have it in one session and they want to talk through everything. But for other people, you need to have these discussions over a number of sessions. It might take, a period of time to get there. Does that help, Gary? Or does anyone want to add anything?
Julie, I think from my perspective, what you've described is how the advanced care plan is really the very heart of the whole care plan. Without that, it's extraordinarily difficult to coordinate and to know where we're going and what happens next. I think that highlights really well how critical that document, or that discussion, is not a document, that discussion is. Did anybody else want to make any comments about advanced care plans and how important they are?
This is Jane. Yes, I do.
Yes, Jane.
I took a copy of ours of Robert's, and I had it in my handbag, and I also took photos of it and had it on my phone at all times, because if you you have to call an ambulance and you're rushing somewhere, the last thing you're going to think about doing is picking up your bits of paper. But if it's on your phone, you can show it to the whomever when you need to. Otherwise, you won't be listened to.
Yeah, a great piece of advice. Thank you. And look, I just need to make a huge apology. When I talked about the Ask Annie app, I misnamed or misspoke. It was actually Fight MND and Dementia Australia who worked together, and we produced, thanks Jane, and we produced 3 modules. I know Motor Neuron Disease Australia have a really important relationship with us, but those particular modules in the Ask Annie app were actually funded by Fight MND. So thank you very much for their support there. Taylor, I'm just looking at the time. I'm just wondering if we have time for one more question for the panel.
Just getting that one up now. There was a question in here that was about any recommended communication devices to help communicate when somebody is late in their motor neuron disease journey.
I might throw that to Sally. Sally, would you like to comment on that question?
Yeah, thanks so much. And that's a really great question, because as we've discussed today, like, it is tricky. Communication does change in many ways throughout MND, and then it changes again if we have MND and frontotemporal dementia. So this is firstly where I would say having a speech pathologist as part of your allied health team and your team is really crucial, and understanding that, you know, speech does change, and these can really have an impact on the person and the carer. It can be really frustrating, it can be isolating, it can be anxiety producing. So we do want to be sensitive and as patient as we can be with our loved ones and their carers around this. The speech pathologist really will be looking at personalised strategies to support communication. So that's where they'll really work with the person, with their physical and cognitive ability, and find the right device for them. There are iPads with speech generating apps. Some you pay for, some are free and still pretty good and worth a trying. There are writing devices such as a boogie board if the person can still use their hands quite well. They're very affordable. They're about $50 and they're a really excellent quick little tool. There's also bigger, sort of more expensive devices such as eye gaze devices, and what they have is speech generating apps in there where a person may have done voice banking previously. So they've recorded their own voice and that is what is speaking out. The sentences that the person puts together. There's also that with MND we have breathing that may be affected as part of the disease process, and sometimes when you can't get your breath, it's hard to speak in a large amount with enough volume. So we have voice amplifiers as well that can help to with that communication. So there are a lot of devices out there, and it's really about trialing those few to find the right fit for the person. That's dependent on their physical and cognitive abilities.
Gary, could I just say something around speech? Not necessarily
Yes,
speech,
please.
but it's very important that you speak to the person with MND. A lot of times the person with MND is ignored and their carer is spoken to. And I see this happen time and time again. I see it happen in home, I see it in community, I see it happen in hospitals. It's frustrating to wait for the person to respond to you but they've lost power over everything else. So it's extremely important that you speak to that person. Now, they may give up and point to their carer and ask you to ask that question, but it's imperative, really, that we recognise because this person cannot speak doesn't mean that they are impaired mentally in any way in most instances.
Oh, look, thank you for that comment, Jane. I think that it's such a common experience, I think, for people with any diagnosis of any dementia or a whole range of conditions, even as we get older and we're accompanied by our, our children to so often healthcare workers or healthcare workers in particular, I think, speak to the younger person before acknowledging that the patient, the resident, the person with the diagnosis, very often is quite capable of speaking for themselves or letting you know that they can't or are not interested in talking today. So it's so important that we focus on the person. So thank you for that. I'm aware that we've got about 2 minutes to go. I'm just going to open to the panel if there are any last things that you'd like to say, just being aware you've got about 10 seconds to say it. Anybody want to make any final comments?
Yeah, I always talk, so very quickly. The most important thing, as I heard people speak before when I could hear and not see, is it's all about communication, communicating with the person, with the family, and with the other carers, doctor, any other support staff. The communication is vital.
The absolute heart of the whole process. Thanks, Jane.
And I think just adding on very quickly, sorry, Gary, to that as well is, communication across the whole team is really important, and sharing some of those changes across the whole team too. We really want to try and anticipate what's happening for this person. So any small change with their symptoms is important to let the whole team know. It's the only way we can try to avoid a crisis situation. If we can kind of track when little symptoms are changing or new things are happening or weakness is progressing and the whole team's aware of that, we can start to plan ahead. We can start having those conversations. We can organise the right equipment to be in the home so that it's there ready when we need it. So I think, communication is so key, and just keeping everyone up to date with the changes that we're all noticing.
I think that's a really lovely place to finish on, that importance of the whole team working together. Look, can I thank everybody who came along, to Jane, to Julie, to Sally, and to Dr. Marie-Claire. Look, thank you so much for sharing your expertise and your passion. Can I also thank from the Dementia Australia team, Jim, Vicky, Taylor and Jackie. There's always a cast of thousands in the background. I hope everybody in the audience has found this webinar as fascinating, I have to say, as I've found it. It's not an area that I have a lot of experience in. So what we will do as well is we'll take the 5 top unanswered questions and we're going to present those to our panelists, and they can cogitate on those at their leisure, and we'll feed that back to all of the audience. So thank you all very much for your participation today. It's been a really fascinating conversation. Thank you.